like Dr. Marshall said, what I'm going to try to do, this is a very complicated and certainly intimidating topic for, I would say, for all health professionals. This is not really one disease. It's a group of diseases that share some common features and are lumped together for a lot of reasons, historical and also practical. There are things that if we know how to approach the patient with lymphoma and classify them from the outset, try to make distinctions of the different types of lymphomas, but as a group, then we can, it becomes very easy to sort out at least the diagnostic possibilities, the management, and the prognosis. So some of the slides are a little bit busy. I'll walk you through them, but many of them you don't. I just want to show you how complicated it can get, but we're going to make it very simple. Patients don't present with a diagnosis of lymphoma. You all know that, and we were talking about that 2 seconds ago with Dr. Marshall back there. Is patients come with a complaint or with symptoms. And this is a dramatic example of a patient with lymphadenopathy. In 1996, we rarely see this degree of adenopathy as a presentation of lymphoma, but it's still, there are very quickly growing tumors that can present very dramatically. But patients come with a diagnosis, the patients come with a complaint of, I have enlarged lymph nodes. And they can have associated symptoms, they can have fever, they can have weight loss, or they might be perfectly asymptomatic otherwise. So the first thing I want to approach is how do you manage the patient that presents with lymphadenopathy, okay? The first thing you don't go and do a biopsy right away, okay? Let me say that. The first thing is, like everything, is a history and a physical examination. And you have to take into account the age of the patient, the symptoms associated with that lymphadenopathy. Do they have fever? Do they have weight loss? Do they have pain? How long, and this is very important, how long have they had this lymphadenopathy? Have they been in contact with somebody that had a viral illnesses or any type of illnesses? That usually gets, it gives you a good handle of what's going on. All of us develop lymphadenopathy very frequently when we have the flu, when we have all these viral syndromes that we seem to catch when we work in hospitals, and we don't pay too much attention to it. But I can tell you every so often I develop some sore throat and I can palpate 3 or 4 lymph nodes, and the last thing I think, although it crosses my mind, is, gee, can I be developing some lymphoma? But it's really, the history is very important. And if somebody comes to you and says, well, I had this for 2 weeks, and I had a sore throat, or my kids had something, I mean, the overwhelming majority of these lymphadenopathies are going to be related to some transient viral infection, and it's not going to be a big differential diagnosis dilemma. But things that you have to pay attention is persistent lymphadenopathy, sometimes for weeks or months. Okay, it's very, and sometimes for years. I'm going to show you a group of diseases that characterize by long-standing lymphadenopathy years, and actually that gives you a lot of information regarding the diagnosis that patient might have. Yes?
Will these small lymph also be tender upon palpation?
Usually if they're infectious, yes. That's usually a feature that tells you, gee, we're dealing probably with an infection cause. That's not 100%. That's a good differential diagnosis point. Just like most cancers, when you palpate a mass, it's usually painless. So that's an important, as well as the associated symptoms. So that's absolutely right. So basically, when you have a suspicion that you might be dealing with a pathologic with a pathologic process that is more serious, at a transient viral infection, then you think about a lymph node biopsy. And I always tell the house staff and the nurses in the hematology oncology unit that like any test, when you do a biopsy, you need to know what you're looking for, okay? If you start biopsying people that come in with lymphadenopathy, you're going to diagnose a lot of things that maybe you don't, that might be misdiagnosis because, God knows how some lymph glands look after a bad case of influenza. It's not something we do every day. It's something that can trigger a very bad series of events. So you have to clinically decide who can really have the possibility of having a pathologic process like lymphoma, and then you move and do the biopsy. And the questions that you want to answer are basically this. Is this process an orderly immune response? Because if it is, the chances of that being infectious rather than neoplastic are high. Are there features that suggest a specific cause like infection? Every once in a while we diagnose diseases by biopsy that should have been diagnosed in some other way, but the disease behave a little bit differently, or the patient didn't complain of other things that would have pointed you towards the right diagnosis. An example is tuberculosis. Every once in a while, we find a patient that presents with adenopathy, is painless, it's been there for weeks or months, the patient has fever, is losing weight, you say, oh, this guy has cancer, tuberculosis, or a lot of other infectious diseases. Another thing you want to determine is, are we dealing with cancer or not? Okay, before we start worrying about, is this type of lymphoma or that type of lymphoma or metastatic carcinoma, pathologist needs to tell you, this doesn't look like cancer. This is something else. Could be infectious. And if it's indeed lymphoma or a different cancer, and the pathologist is able to tell you, what is that going to mean to the patient and to you as a therapist? Does this mean that we have to treat the patient? As you will see, sometimes we don't. Does that mean that we need to treat the patient aggressively or the patient is going to die right away? All those things should be tried to be addressed when you get your pathologic specimen. One of the, I know my talk is Hodgkins and non-Hodgkins lymphoma, and for practical reasons I'm going to address non-Hodgkins lymphoma first, because it's historically, it was the first tumor that was cured with chemotherapy. It's the one that they seem to ask you when you take all these tests, whatever boards you're taking or recertification, they will ask you about Hodgkin's disease. And the other thing is, it's something you don't want to miss because you can cure it. So there are tumors that unfortunately the diagnosis might be delayed for one reason or the other, but really it's not going to make a lot of difference because there's no good therapy for it. So if you diagnose it 1 or 2 months later, it's really, unfortunately, it's not going to be impact very much on the management of the patient. But this one is a disease, Hodgkin's disease, is a disease that you can cure in the overwhelming majority of the time. So this is something you don't, oncologists and hematologists don't want to miss or misdiagnose. So this is the famous Reed-Sternberg cell that probably you read or heard about in some textbooks. And as you can see, it's a fairly large cell. It's binucleated, and each nucleus have a very prominent eosinophilic nucleoli. So that's the famous Reed-Sternberg cell. And when you see that, that is Hodgkin's lymphoma until proven otherwise. Okay, and that's one of the things that we look when we do a biopsy and we consider Hodgkin's disease is part of the differential diagnosis. And in a sense, if you're going to have a lymphoma, this is a good one to have, in the sense that it's curable in the overwhelming majority of patients. Something that is important both for Hodgkins and non-Hodgkins, it's the staging of lymphoma. And this is very important because you will see that in the management of lymphoma, the first thing you have to do is take a good history, physical examination. Do you think this is lymphoma or a malignant process? Then you do a biopsy. If it turns out to be a lymphoma, the next step is staging, okay? Because it's not the same to have stage 1 Hodgkin's disease than having stage 4 Hodgkin's disease. And I'll show you why in a minute. And staging sounds very complicated, but it's not. Basically what we do is, again, a good history, physical examination, routine labs, CBC, chemistries. We do certain laboratory, more sophisticated laboratory procedures such as the bone marrow to determine if the tumor has spread to the bone marrow. And then we do radiologic studies to determine, the extent of the disease. And that in practical purposes mean a chest, abdomen, and pelvis CT. Sometimes we have to do some neck CTs, but they're not necessarily very helpful. For some patients, you might need a more detailed evaluation, MRIs, or because you cannot determine if an area is involved. But 90% of your evaluation is that. Some are things that are very practical and available in most institutions. One test that we don't do very often these days is a lymphangiography. Because radiologists are very reluctant to do this type of test. Basically what that means is they put some dye in both, probably you remember that or seen that, they put some dye in the veins of the lower extremity, and then they take x-rays. Usually that dye migrates upwards and goes through the lymphatic system, and it's actually a very good way to determine if some lymph nodes are involved. And in this era of CT scans where everything is very sophisticated and sexy and expensive, they're excellent, but one thing that we forget is that what CTs tell you basically is size of a lymph gland. And it doesn't tell you much about the architecture of individual lymph nodes. With lymphangiography, you take a look at the architecture of that lymph node, and many times, not only can you tell if it's enlarged, but you can tell if it looks abnormal, and it's probably involved by Hodgkin's disease. So, unfortunately, it's not done in most places. Every once in a while, we convince a radiologist to do it, but they have lost the ability to read that, very well because they don't do it very often. So. But that's basically it. Chemistries, CBC, CT scans, sometimes lymphangiography, and obviously history and physical examination, and a bone marrow. With those things, you should know where you stand. You should be able to stage your patient, which is the next, probably you heard this before. It sounds complicated, it's not. And this applies both to Hodgkin's and non-Hodgkin's lymphoma, but this classification was initially designed for Hodgkin's disease. And they go from stage 1 to 4, and it's very easy. Stage 1, it's involvement of a single lymph node region. So if a patient presents with lymphadenopathy, lower cervical lymphadenopathy, and the rest of the physical examination, CTs, bone marrow, etc., it's negative, stage 1. Very easy, straightforward. Stage 2, more than one, in this case there's 2, but it could be 3, or more than one lymph node region on the same side of the diaphragm, okay? So this patient that has two areas of lymphadenopathy, could be 3, but on the same side of the diaphragm, that's a stage 2. If you have disease above and below the diaphragm, automatically you're stage 3. okay? So even if you have, let's say for example, low cervical adenopathy and inguinal adenopathy and nothing else, you're stage 3 because you have disease in both sides of the diagram. And that has treatment implications. It's not that necessarily, but that has treatment implications. And then stage 4 is disseminated disease, okay? And disseminated disease basically means the following: bone marrow involvement or liver involvement, okay? Or for example, some patients that have pleural effusions with lots of disease there, we call it disseminated disease. That's basically, in practical terms, those are your patients with stage 4 that are still curable, by the way, okay? And these apply to non-Hodgkins lymphoma too. One change that we have realized in the last few years is some patients present, let's say, with a pulmonary mass. It's not really a lymph gland, but a pulmonary mass, and that's the only site of disease, okay? We don't call that, even though you will think, well, this could be stage 4 because it's in the lung, it's, systemic disease. We have learned that those patients behave like stage 1 patients, so they are called 1E, 1 extranodal, stage 1 extranodal. So if we say, little quiz here, you have a patient with cervical adenopathy and mediastinal adenopathy. Remember, there are lymph glands in the mediastinum. What stage will that patient be? 2. Okay. Now it's a tough one. Let's say a patient has a pulmonary mass and has mediastinal adenopathy, and both of them are Hodgkins. What stage are those? That's the toughest one, so if you bat that one out, I'm gone. Yeah, I heard something that sounds correct. What was that? 2E. 2E, exactly. Because you have a group of lymph glands and another site of disease, it's 2E. That's the toughest that you can, okay? So it's very straightforward and very practical, as you will see. Okay. One thing to remember about Hodgkin's disease, and you deal with geriatric patients, the idea of Hodgkin's disease that many people have, it's a young male or female with cervical adenopathy, maybe mediastinal adenopathy, and that's the classic Hodgkin's patients. But people forget that Hodgkin's disease have 2 peaks in the incidence. The incidence of the disease, there's an early peak, like in the late teens, early 20s. There's another peak in the 60s. So it's possible that you will get to see Hodgkin's disease, and some people question the diagnosis. A 70-year-old man with Hodgkin's disease, and they say, oh, that's a disease of young people. Well, they forget that there are 2 peaks of the diseases, early in life and late in life. Don't ask me why, okay? Nobody really knows why is that. But chances are that you will see Hodgkin's disease because of this secondary peak. So that's important for you to remember. Okay. Now, in terms of treatment, okay, you have an old patient or even a young patient with Hodgkin's disease. Well, the first thing to remember is this is a curable disease. So that's why we don't want to miss this type of diagnosis. And for the first rule of thumb is for localized disease, we will give radiation therapy, and it's curative. And for disseminated disease, we'll institute chemotherapy that is also potentially curative. Okay? So let's say we have a patient with stage 1 low cervical adenopathy. What is the treatment? Radiation therapy. Okay? And this slide illustrates different fields of chemotherapy. This is not important. You don't need to know the details of this, but just to give you an idea, when you read about these diseases, this port 1 is what they call the mantle port, for obvious reason. It looks like a mantle, and it includes from the lower part of maxillary nodes all the way down to your mediastinum, okay? Submandibular nodes, I'm sorry, and include the axillary nodes. Sometimes that's all you need to cure a patient with Hodgkin's disease. 4,000 or 5,000 rats for localized disease, and they're cured 90% of the time, 95% of the time with that type of therapy. We usually, I'm not a radiation oncologist, I have to tell you that, but usually, in addition to this port, many oncologists tend to give an additional port just in case there's disease there. One thing that is interesting and nobody knows why is Hodgkin's disease appears to spread in an orderly fashion. In other words, if you have, for example, cervical adenopathy, they tend to have mediastinal adenopathy, axillary adenopathy. It doesn't seem to skip regions as non-Hodgkins lymphoma does, although it's frequently it spreads that way, but there are all sorts of variations. But the therapy takes that into consideration, and sometimes, most of the time, they get additional radiation therapy. This is what they call the para-aortic node, and this is what they call the inverted Y node for obvious reasons. So let's say we have a patient with stage 2 Hodgkin's disease. How would you think that most people will approach that patient? Let's say cervical and small mediastinal adenopathy or axillary. Radiation therapy too. Stage 1 and stage 2, as a rule of thumb, radiation therapy. How many do we cure in stage 2? A lot of patients, 85, 90% with radiation therapy only. Now, stage 4, let me jump to stage 4. That's chemotherapy, okay, because you have disseminated disease, so by definition, you have to give systemic chemotherapy, and it's very difficult to deliver radiation therapy to your whole body. So that's chemotherapy, and I'll show you some combinations. It's not important, but it's curative too. The controversy arises in stage 3 patients that have disease above and below the diaphragm. What is the best way to approach those patients? Is controversial. Some people give chemotherapy to them. Some people give them all these radiation therapy, or what they call total lymph node radiation. Is delivering radiation to all those ports. Okay? Again, a significant number of these patients are cured, 75, 80%. If not, they can be treated with chemotherapy. Okay? So you're curing the majority of patients. How many patients with stage 4 disease, and this is the worst, bone marrow or disseminated disease, do you think we cure with chemotherapy? At least 50%. So it's very good. If you compare, we're talking about cures. We're not talking about responses. We're talking about cures. So this is a very treatable tumor. Okay? The chemotherapy is not important. These things change every few years, and the reason I brought this slide is to remind you that the so-called MOP chemotherapy, MOPP, was the first chemotherapy that was proven to be curative in any tumor. And it's nitrogen mustard, vincristine, procarbazine, and prednisone. It's not used that frequently today because it's quite toxic, very emetogenic, the nitrogen mustard and the procarbazine. It has a lot of side effects, especially long-term, that we'll talk about. But it's as effective as anything. And now we have other chemotherapies that are as effective, but with less side effects. But it's something like medical culture. Somebody might ask you, well, the history of chemotherapy, and it started basically here, in terms of curative treatment. And of all those patients that we could not cure, we still have options. One thing to remember that people seem to forget, and sometimes our house staff forgets, is that patients that fail radiation therapy can be salvaged with chemotherapy frequently. okay? So you don't have any tumors where you can say that when you think about it. And patients that fail radiation therapy, a significant proportion of them can be cured with chemotherapy. Patients that fail both conventional chemotherapy and radiation therapy, we still can cure a percentage of those patients. And this is from our own institution. One of our fellows looked back all the bone marrow transplants that we have done for the last 7 years for Hodgkin's disease, and he found that we cure about 50% of those patients. And these patients are patients that have failed sometimes 2, 3, 4 regimens of chemotherapy and radiation therapy. So it's a very treatable disease. This is a Kaplan-Meier curve in which you have the probability, in this case, of being alive and free of disease months or years after your transplant. And whenever you see a flat line, that suggests that you're dealing with cures. Okay, so and you can see here that sits around 50%. So it's a very treatable tumor. Something that is very important and people minimize, and probably you will see, is the long-term complications of Hodgkin's disease. Either because your patients 15, 20, 25 years earlier had this type of treatment, or because basically patients will last more and more, and we will see these patients that are cured today of Hodgkin's disease will be part of the geriatric population in the next few years. So we're starting to see, unfortunately, long-term complications of the therapy of Hodgkin's disease. Bone growth abnormalities is usually in kids, but something very frequent in the adult population is hypothyroidism. Why? Well, if you remember your mantle port, remember that the thyroid was radiated during the therapy. And even if you shield the thyroid, you can still get a significant amount of radiation and have hypothyroidism. And I don't have to tell you that hypothyroidism could be pretty difficult to diagnose, especially in the geriatric population. I mean, it's a challenge. You really have to think about it in many instances because, you know, they don't have the usual features. So it's something to keep in mind. If a patient was treated with radiation or for some tumor, sometimes they don't remember what they were treated for. It was 25 years ago. So you have to. Infertility, certainly in younger population, is a very serious issue. Many of these patients develop radiation pneumonitis because, again, the radiation to the chest. Many of these people develop early or late coronary disease, even without a history or without risk factors. Nobody is really sure why it's that, but it's certainly a problem. And the most distressing, at least to me, is the fact that many of these patients are developing secondary tumors after being cured of a disease like Hodgkin's disease. And this is something that we are seeing more and more, unfortunately. What are those second neoplasms? Usually acute leukemia or other type of lymphoma, like the ones we're going to talk in a few minutes. But there are some solid tumors too that we see. For example, lung cancer, very distressing. There has been some other solid tumors like sarcomas in the chest wall because the patient received radiation and chemotherapy. It's usually seen in patients that were treated with both modality of therapy, radiation and chemotherapy, but still can be seen in patients that receive only one of them. And it's one of the most frustrating things that at least I have to do, is to tell a patient that has a second malignancy after being cured of a terrible disease years ago. And unfortunately, these things are not easy to treat. Many of them are not curable, and we really don't make an impact. And many of the patients die of the second tumor rather than of the original diagnosis. Okay? So in a nutshell, that Hodgkin's disease. Okay? If you remember those things, you know more than 95% of the house stuff about Hodgkin's disease. And that's what you need to, more or less, how to make the diagnosis. Is it localized or disseminated disease? that will dictate your prognosis and your therapy. Very straightforward. Okay. What about non-Hodgkin's lymphoma? It's a little bit more complicated, but we're gonna try to simplify it and make it, instead of dealing with 15 or 20 types of lymphoma, we're gonna deal with 2 groups of lymphoma. And that will let you more or less have an idea of the diagnosis, prognosis, and therapy of this group of diseases. And why bother with non-Hodgkin's lymphoma, you might ask? I mean, it's really not a common disease. It's not. There are about 50,000 new cases and 20,000 deaths. There were in 1995. That was the projection. So compared to breast cancer or lung cancer, this is not that common. But for reasons that are not clear, the incidence of non-Hodgkin's lymphoma is going up dramatically, and nobody really knows why. There are many theories. Are we exposed to more chemicals? Is the population lasting longer so you have time to develop tumors? Is this a combination of things? Are there genetic factors? Are there infectious factors? We really don't know. But the incidence is escalating very quickly. And approximately 50% of these cases is what we call low-grade lymphomas, which are less aggressive but still a problem, and we'll go into that. This is not to, I was trying to find one slide that will summarize the histology, but I couldn't. So you need to be familiar with something called the working formulation for the classification of lymphomas. This was an effort from the National Cancer Institute about 15 years ago. There were so many classifications of lymphoma, some European, some American, that people were not speaking the same language. So a group of experts sat down and revised, I don't know, 15 or 20,000 cases, and decided to lump them into 3 categories called low grade, intermediate grade, and high grade, and try to make the people speak the same language. And they did. They were able to do that. Most people understand the working formulation and use it to a certain extent. The problem is that the biology of lymphomas is changing every day. So more diseases are being described. Variations of lymphoma are being described every year. So there are other revised lymphoma classifications that you will see that maybe are a little bit more correct scientifically. But this is very good, this working formulation, because it was the first one that attempted to lump this in different grades. And that's the approach we're going to use. They basically divided in 3 categories: low-grade lymphomas, intermediate grade lymphomas, and high grade lymphomas. And I want you to memorize each one of them. Now, just kidding. Actually, we're going to make it more simple. We're going to make them 2 big groups of lymphoma. We're going to call them low grade lymphomas, and the other group we'll call intermediate and high grade lymphomas. Okay? And if you can push your pathologist or clinician to tell you, no, this is a low grade or this is an intermediate or high grade, it's a piece of cake, believe me. So how are we going to do that? Well, if we look at several pathologic and clinical features, we'll see that there's a contrast between these 2 categories. Low-grade lymphomas are what many of you have heard as nodular lymphomas, or some people use terms like favorable lymphomas, indolent lymphomas, nodular or follicular. I don't like the term indolent, I must say right away. To have lymphoma, if they tell me I have lymphoma, I would be pretty upset. Okay? Even if they tell me it's a low grade, oh, okay. This is not a cold. And the reason I'm stressing that is that sometimes the house staff, for example, or people that don't have a lot of experience, they say, well, tell the patient, hey, you have you have cancer of the lymph nodes, and the patient becomes very upset, and he should be. And they say, but listen, don't worry. This is a low-grade lymphoma. Or same thing happens to chronic lymphocytic leukemia, which you see very frequently. Oh, chronic lymphocytic, don't worry, Mr. Smith. I mean, this disease might not kill you, and it's true, you know. But there's a wide range of these diseases, and some of them will kill the patient. And people have used this low-grade category, and they have said, well, you know, these are usually older patients. The median survival is 7 or 8 years. Chances are that he will die of heart disease, and a significant number of patients will. But we have to remember that many of these patients will get worse, will progress to a worse lymphoma, and will die of this disease. So this term indolent, I don't like very much. But the reason I put it there is you'll read about it, you hear about it, and people get the wrong idea sometimes. Now, compared to the high grade, well, you know, it's somewhat better. Why? Because high grade and intermediate grade lymphomas are rapidly progressive. This is the patient that develops a lymph gland a few days, a few weeks ago, starts losing weight, feels lousy, develops, you know, organ failure because he has dissemination to the liver or to the bone marrow. This is a different disease. I mean, these patients quickly deteriorate, and when people diagnose this, they say, hey, at least it's not a high grade, you know, it's better, but it doesn't mean that it's a good disease. So one of the contrasts is that in low-grade lymphoma, you have a slower clinical course, you have sometimes multiple recurrences, but it can be treated, and the patient lives for years in many instances. High-grade and intermediate grade are rapidly progressive tumors that must be treated right away or the patient dies. Okay? So that's one important difference between the low-grade lymphomas and the aggressive or high-grade and intermediate lymphoma. Response to therapy. Some people say, hey, don't you say that this is the bad tumor that grows rapidly, needs therapy right away? But it's potentially curable. I said, yes. It's paradoxic, but these are the type of lymphomas that you can tell the patient you're cured. You can cure those patients. Contrary to this one that have a slower clinical course and can last years, these are not curable. And usually the house staff thinks, oh, I know what that is. I know what that is. It's because the tumor is progressing so quickly that you give them chemo and they are more sensitive to chemotherapy, and you can kill all the tumor cells and the patient is cured. Well, yeah, it's a good way of remembering that. I'm not sure that it's exactly correct, but it's a good way of remembering and seeing it. Maybe because these tumors divide more quickly, they are more sensitive to chemotherapy, but I'm sure that's not the whole story, okay? The terms that they use for this type of diseases, they call it aggressive, diffuse, and I'll show you why. Sounds mysterious, but it's not. And unfavorable. That's another term that you will see and you will read about. The other thing to remember is that low-grade lymphomas, again, it's paradoxic, but low-grade lymphomas, even though they have a slower clinical course, at the time of presentation, most of the time the patients have disseminated disease. For example, classic presentation, old man, 80 years of age, 85 years of age, persistent lymphadenopathy for months or maybe years. He didn't pay attention. He didn't have any weight loss, any fever, any associated symptoms. It never bothered him. But one day the doctor examined him. One of you guys, you find that they have a 2 by 3 centimeter axillary node or cervical node. A biopsy is done and he has a low-grade lymphoma. So, well, it goes along with the history. When you do a staging, you do a bone marrow, even though his counts are normal, blood counts are normal, chemistry, and the bone marrow is involved with lymphoma. Even though the counts are good, the patients feel right, it's the typical presentation of low-grade lymphomas. Okay? Patients with high-grade or intermediate grade, it's variable. You can have disseminated disease, but you have localized disease very often too. So, how are we going to classify these? You know, there are 15 or 20 types of lymphoma. What is this nodular and diffuse business? This is a normal lymph node, okay? And this is a mesenteric lymph node, so you don't have the usual nice capsule here, but it's still a normal lymph node with their germinal centers, etc. Compare this biopsy with this one. What can you tell it's different? Well, looks like a very disorganized growth, doesn't it? When you compare it with the this is the let me see if does this thing go backwards? Can we I think both of them move it forward. I'm sorry. I was trying to make it a little bit easy to compare. Okay. One more. Okay. Okay. Good. Compare this one, okay, to this one. This is certainly tumoral. I mean, you don't have to be a pathologist to. And there's a very disorganized growth. You can see the nodules that doesn't seem to have. Some of them are really very close to each other. There's no that normal architecture of the lymph node is totally lost. But you can also see that some nodules remain. Okay, actually they do not correspond exactly to the nodules in the normal one in the normal lymph node, but you can see that there's some nodular growth pattern. This is what we call a nodular lymphoma. That's what they call it, a nodular lymphoma. Okay, as a rule, and this can become very complicated, and there are people that they devote all their time to classify lymphomas, and it's very. But if you know this is a nodular lymphoma, and you can classify yours as, you know, you have 90% of your fight with the histopathology one, and this is what we call nodular lymphoma. These diseases tend to be more indolent. Again, I hate the term, but less aggressive. Okay, and patients last years, and most of the time incurable. Most of the time disseminated disease. Okay. What about this one here? There are no nodular pattern whatsoever. That's what they call a diffuse lymphoma. Okay? And that's a bad actor. Okay? Those are the ones that crash very quickly, are curable. Okay? Might or might not be disseminated at the time of disease. Need to be treated right away. Okay? So nodular versus diffuse. That's all the mystery. This is what it's all about. Nothing. Even I can tell that. The other component of histopathology that you need to know is the type of cell that predominates in a given tumor. These cells are, if I show this around on a slide, I say, well, this looks like normal lymphocytes, and they do. And this is what they call small lymphocytic tumors or well-differentiated lymphocytic lymphomas. This is like CLL. It's better to have this than to have large cells like this. So large cells are bad. Small cells are usually, generally speaking, they are more favorable. And then, like everything in medicine, you have combinations. Like this patient has some large cells, and then it has some of the small cells. Okay? So knowing that, if I tell you a patient has diffuse large cell lymphoma, is that bad or worse? None of them are good, but if you have diffuse large cell lymphoma, high grade, intermediate grade, or low grade? High grade or intermediate grade. Diffuse and large cell component, bad combination. If they tell you you have a nodular, well-differentiated lymphocytic lymphoma, that's good, low grade. Nodular, well-differentiated cells. And you can basically, what you need to, and you don't need to know every pathologic variation, but when you have a patient with this, what you need to know from your pathologist, and we do this all the time, I ask them, listen, if this were a classification of lymphomas, where do you put that patient? Are we dealing with a high grade, at least histologically speaking, are we dealing with a high grade aggressive lymphoma, or does this look more like an indolent lymphoma? And he usually tells you, this belongs to a low grade category, so you know where you're headed. On the other hand, if they tell you this is aggressive, has diffuse features, then you know that how this disease is going to behave without having to know everything about that particular subtype. Okay? So again, this is the so-called nodular versus diffuse pattern. And if you know these things, you have 90% of your battle with lymphoma won, because in practical terms, those are the things that you need to address. One thing that it's very difficult to understand for some people is the fact that the high-grade aggressive is the one that you can cure. And these, again, are Kaplan-Meier curves. Remember, whenever you see a flat curve, there's a possibility of cure. When you see a curve like this that doesn't have a flat component, that means that people keep dying as time goes by, and you don't see a flat line because you don't cure anybody, okay, and there's no disease. And when you tell patients, when you ask the house staff, well, which one is more curable, what is better to have or less good to have, and they always jump and say, well, intermediate and high grade you can cure, but so you lose some people. The low grade, they walk around, they come to the clinic, sometimes we don't treat them. That's not a bad disease to have, and that's not necessarily true. If you live long enough, it's going to be even worse. 6 years after the diagnosis, at least the people that survive at that time are probably cured, while patients with low grade, you keep losing them and you don't cure them. So if you live long enough, chances are that your lymphoma will get more aggressive, will transform, and will kill you. And that's something to remember, okay? This is just to remind me to tell you that for the intermediate and high grade, there are several chemotherapy programs. All of them are curative. How many of these patients do we cure? Maybe a third or 40% of them, okay? A few years ago, we thought we cured 60% of them, but that's not true. Those were highly selected patients. The message is very gentle chemotherapy, generally speaking, is as good as very aggressive chemotherapy. And in the geriatric population, we always assume that patients do not tolerate chemotherapy, that they're going to die, that you cannot treat them. And in our experience, that has been totally false, okay? I like to talk more about biologic age than chronological age, okay? And if you have good organ function, renal function, liver function, and you have an understanding of what chemotherapy is all about, you shouldn't deny care to these patients, because you're going to be curing a lot of them, and if you assume that they won't tolerate this, you're basically going to miss the boat. I can tell you for multiple myeloma, which is a different disease and probably worse than this, we transplant patients up to the age of 70. And I can tell you it's very rewarding to see these guys walking around, bone pain got better, they're back into a better, to do the thing, they are able to do the things they were able to do before the diagnosis, and it's very rewarding. We have even looked at patients that underwent bone marrow transplantation that were over 55 years of age, but all the way to 70. Because we use 55 because that was like the magic number where many centers decided they're not going to do allogeneic bone marrow transplants. And we have found that the toxicity is the same, probably with the difference of cardiovascular. And it's not that more people die, but they get more symptoms like arrhythmias, etc. So even when we fail to cure the patients with standard chemotherapy, we transplant some of these patients, and again you see that we cure 40% if they're disease is still responding to chemotherapy. Many of these patients quite old. So the aggressive lymphomas are curable with chemotherapy. Therapy should be instituted in most patients unless you have a very good reason, because they will die quickly and because you can cure some of them. What about low-grade lymphomas? Well, here it's a little bit more complicated. You have many options, and whenever you see a set of options like this, that tells you that the treatment is not that good. Because if it were that good, you will have one or two, but you have many. And they range from watch and wait, meaning that you don't institute therapy until the patient develops symptoms, all the way down to high-dose chemotherapy and stem cell transplant. And the reason for this watch and wait is that you have patients that can be, the rationale is you say, well, is this a curable malignancy, yay or nay? Well, it's not a curable malignancy. With the exception of very localized disease, which is almost unheard of in this disease, that you can radiate, most patients are not curable. So some people argue, why give chemotherapy for something that is not curable? Why don't we watch the patient, and when they develop complications from the lymphoma, then we give chemotherapy? And it's accepted in many instances to do that, especially when you have a totally asymptomatic patient that have small lymphadenopathy. With time, you have to treat many of those patients because those lymph nodes grow. Single agent chemotherapy as a palliation works very well. Combination chemotherapy, when the disease gets a little bit more aggressive, needs to be instituted. And one of the problems with low-grade lymphomas is with time, it progresses. It changes to a more aggressive type, but it's not as treatable. And that's why you see these very aggressive modalities like bone marrow transplantation here. One thing that you need to know is that one of the prognostic categories in patients, or prognostic features in patients with low-grade lymphoma, is age. Okay, age is, if you're over 60, these diseases tend to behave a little bit more aggressively than if you're less than 60, and nobody knows why that is. The other one is response to chemotherapy. And just to illustrate this low-grade lymphoma business, how bad it could be, is to look at the age-adjusted mortality for patients. And all these percentages, what they mean is your chance of, your expected percentage risk of 1 year mortality. So in the general population, if you're 50 to 54, your chances of dying in the next year are 0.6%, pretty low, okay? But if you have a low-grade lymphoma, that one that we say, well, it's not bad, it's not bad, and you never had a response to chemotherapy, your chances of dying in that year, it's 41%, which is like 80 times of what. So it's not a good disease to have, and it's something to keep in mind that some of these patients need treatment early, or at least we shouldn't tell them, gee, your disease is not very serious. This is just a series from patients with low-grade lymphoma at our institution. I just want to call attention to the fact that we have transplanted patients up to age 67. And we have found that there are some long-term survivors even years after the diagnosis, and these patients were kind of transplanted at the end of the line when they failed chemotherapy and other modalities of treatment. Okay, so in summary, what can we say about the non-Hodgkins? It's an heterogeneous group of diseases. It's just not one entity. You need to talk to the pathologist and make sure he gives you a category of aggressive versus indolent, because that will help you in the management. The stage of the disease is important, at least in many of these non-Hodgkins lymphoma. The treatment modalities could vary from observation, like in the watch and wait approach, to very intensive chemotherapy, depending on the type of disease and its behavior. Paradoxically, the most aggressive lymphomas are the potentially curable, and survival of the advanced or indolent, I hate to use the term, but you see it so frequently, is measuring years, but if you last long enough, it will become a problem and these patients will require treatment down the line. So it's important to be able to tell these patients their prognosis and the different possibilities, okay? So if you look at the big world of lymphomas, if you think of Hodgkin's as a group and the non-Hodgkin's lymphoma, you lump them in aggressive versus less aggressive, or intermediate and high grade versus low grade. You know, 90% of what it needs to be, sometimes the internists know about this disease, because you can almost predict what type of therapy, what type of prognosis, and what type of results you're going to deal with. Are there any questions, or did I confuse you more than what I?
That was really good. Because what I hope you do is to make a differentiation between.
Good. Well, I'm glad. Thank you very much.
Great. Thank you very much.
Well, I leave this here.